Hello everyone, this is Dr. Madhusudan Rao and the program I teach medical students. Today my lesson includes vestibulocochlear nerve, that is 8th cranial nerve. About the 8th cranial nerve, the key points of learning are: it is special somatic afferent. It is purely sensory nerve, located in the rhomboid fossa of the brain stem. It has got vestibular and cochlear divisions. It is responsible for hearing and your body balance. Look at this picture. This shows the vestibular and the cochlear division of the vestibulocochlear nerve. You have got the vestibular ganglion here, receiving fibers from the semicircular canals, vestibule, and the article. You have got the cochlear division of the vestibulocochlear nerve, receiving fibers from the organ of or spiral ganglion. Origin of this nerve arises in the nuclear complex. It is a vertical nuclear complex extending from the caudal pons down to the rostral medulla. So it has got two parts, vestibular root and the cochlear root. These nuclear complex receive the axons of the first order neuron located in the spiral ganglion and the vestibular ganglion in the inner ear. They in turn through the second order neurons to cross to the opposite side and will be connected with the higher centers. Well, coming to the vestibular root and the cochlear root. These two roots leave the brain at pontomedullary junction and enter the petrous part of the temporal bone at the internal auditory meters as vestibulocochlear nerve. These two divisions separate at the external auditory meters and innervate the respective tissue, that is vestibular and the spiral ganglion. The peripheral process of the bipolar cells of the vestibular ganglion innervate the labyrinth, that is ventricle, saccule, and the C3 semicircular canals. Whereas the process of the spiral ganglion cells supply the air cells of the basal membrane of the organ cortex. That is for the function of hearing. Well, look at this picture. This is the vestibular cochlear now, leaving the brain at the pontomedullary junction, and it has got the two roots, that is cochlear and the vestibular root, entering the internal auditory canal to reach the organ of cortex and the vestibular apparatus. Then coming to the vestibular nuclei, they are arranged in the two columns, in the lower pons and the upper medulla. Second order neurons in these nuclei supply the reach the higher centers after crossing the midline. The first order neurons in the vestibular ganglion and the spiral ganglion for the vestibular function and the cochlear function respectively. First order neurons and the second order neurons of this vestibulocochlear pathway. The peripheral processes and the central processes. Peripheral processes, they start from the receptors in the labyrinth the labyrinthine apparatus for the vestibular nerve, and the spiral ganglion or organ corti for the cochlear nerve. The central processes from the vestibular nerve trunk divide into two branches, superior and inferior. Superior end of the superior and lateral nuclei, inferior ends in the medial and inferior nuclei. The afferents from here connect the ocular node of the cerebellum through second order neurons. Vestibular nuclei also connect the ocular complex through reticular formation, cerebellum, and spinal cord. Basically, you understand the vestibular nucleus has got the vestibular ganglion in the inner ear. Cochlear nucleus, cochlear nerve has got the spinal ganglia. They have the bipolar cells there. Peripheral axons. They innervate the organ of corti, and central axons from the spinal ganglia reach the nuclear cochlear nucleus in the lower parts. The same way, vestibular nerves from the vestibular ganglia, peripheral processes, they innervate the apical and the semicircular canals and the vestibule. And the central processes, they reach the vestibular nuclear complex and the lower pons and the upper middle layer. They in turn connect the floccular nodal lobe of the cerebellum and also connected with the spinal cord by the vestibular spinal flex at the sacral part of the spinal cord. This vestibular nuclear complex also sends the fibers to connect the ipsilateral oculomotor nerve nuclei. Okay? Whereas the central process of the cochlear nuclear apparatus, they cross to the opposite side, run in the lateral lemniscus, reach the medial geniculate body. From there, they ascend upwards to reach the primary auditory area in the temporal lobe. This is the pathway for the vestibular and the cochlear nerves. That's it. In the spinal cord, they run into the lateral vestibulospinal tract and innervate the lumbosacral region. The ocular complex. They reach the ocular complex through medial longitudinal fascicles. This is already explained. Cochlear nuclei, they are in the rhomboid fossa of the brainstem. Second order neurons from the cochlear apparatus, they form the central pathway to connect the primary auditory area in the temporal lobe, which I already explained. This is the structure of the vestibular and the cochlear nuclear complex, the pons and the upper middle. These are the central roots of the cochlear and the vestibular nerve and entering into the auditory canal. What is the clinical importance? Its importance lies with the conductive deafness, sensory neural deafness, nystagmus, tinnitus, vertigo, nausea, vomiting, and loss of balance. Look at the auditory pathway, which I already explained to you. The nerve fibers and the peripheral axons start from the organ cortex. They end in the spiral ganglia. Central processes, they enter the vestibulocochlear nerve and end at the cochlear nuclear complex and the lower parts. From the cell bodies of the cochlear nuclei, central processes they cross to the opposite side, run in the lateral hemispheres, reach the middle genital body. From there, they end in the primary auditory area and the temporal lobe. This is the auditory pathway in brief. What are the features? Well, eighth cranial nerve is purely sensory, as I told you already. That's called the cochlear and the vestibular roots. Cochlear is related to hearing, vestibular for the maintaining of the body balance and the eye movements. Both have their receptors in the structures in the Peter spot of the temporal bone, that is inner ear. Well, injuries to the cerebellopontine angle or internal auditory canal may result in sensorineural deafness, nystagmus, vertigo, or tinnitus. Coming to the cochlear now, the cell bodies are in the spiral ganglion, which I told you already. The afferents are nerve process of the ganglion cells from the receptors of the organ of corte, continues in the organ of corte and the basal membrane. Well, the pathway has already been explained. I do not want to repeat. In the same way, the vestibular nerve. They have their receptors over the semicircular canals, saccule and atricle. Okay. The axons of the vestibular ganglion form the afferent nerves. Then, what is that you are going to learn about? About deafness. What are the types of deafness? Connective and sensorineural deafness. For connective deafness, the lesion is in the external auditory canal in the form of bags or something like that. The tympanic membrane, rupture of the tympanic membrane, middle ear, that is the what you call fusion of the ossicles, attested by the Rinnes and the Weber's test. Sensorineural lesion due to the lesion of the cochlear system and treated by the cochlear implants. What is the Rinnes test? Air conduction is better than bone conduction. That is normal. A positive Rinnes test is normal. Bone conduction is better than air conduction. It means it is negative Rinnes. It is abnormal. Coming to the Weber's test, it is lateralization to the disease side is indicator of conductive deafness. That is Rinnes negative. Lateralization to normal side is sensorineural deafness. It is associated with Rinnes positive. Then what is nystagmus? It is the slow eye movement followed by rapid eye movement in the presence of stimulus. If that is there, it is physiological. It is slow eye movement followed by rapid eye movement in the presence of stimulus is normal. If you are sitting in the moving train and you are watching the object, the eyeball moves this side or that side. There is oscillatory movements of the eyeball. Okay? A slow movement followed by rapid movement for correction. This is normal in the presence of stimulus. But if it occurs in the absence of stimulus, it is abnormal. So that indicates this is in the labyrinthian system. Then the patient may feel vertigo. Vertigo is nothing but an illusion of rotation of the surroundings. tinnitus, ringing sound in the ear. Low frequency sounds are heard in the conductive deafness. Well, disappear with the treatment of the conductive deafness. High frequency sounds are heard in the sensorineural deafness. Persist even after the treatment. This is the difference. So what are the vestibular disorders? The inflammation of the labyrinth, vestibular neuritis, Meniere's disease, acoustic neuroma, characterized by sudden onset of vertigo. The patient cannot walk, associated with vomiting, and no headache. The episodes last for a few hours and slowly improves over a few days or weeks. But there is no hearing loss nor headache. Coming to the central lesions. Lesion could be in the brainstem or vestibulocerebellar tracts. Occur in stroke, hemorrhage, or tumors. Cochlear nerve pathway has already been described. This is the pictorial representation of the auditory pathway. Look at the spiral ganglion. From there, fibers reach the olivary nucleus. From the fibers cross opposite side to run in the lateral lemniscus. From there, reach the inferior colliculus, ascend upwards to the medial geniculate body, and finally reach the auditory center in the temporal lobe. This is the auditory pathway. Vestibular nerve, its disorders may manifest as vertigo. What is vertigo? An illusion of rotatory movements associated with vomiting. Nystagmus is the rhythmical oscillation of the eyeball. If it occurs in the presence of the stimulus, it is normal. It is usually horizontal, vertical, rotatory, or diagonal unmixed. Cochlear pathway, I already explained. Vestibular pathway, well, cell bodies in the vestibular ganglion. Central processor, they reach the vestibular nuclear apparatus in the pons and upper medulla. And central processors from the cell bodies, from these nuclei, they reach the cerebellum through pontocerebellar pathways, reach the spinal cord by vestibular spinal tracts to the level of sacral spinal cord, sacral segments of spinal cord to maintain the balance. They also send the axons to connect the oculomotor complex. So, vestibular and cochlear nuclei, pons and medulla. Damage produces, as I told you, dizziness, nausea, loss of balance, and nystagmus. To sum up in brief, the central process of the bipolar cells of the spiral ganglion, they contain the first order neurons, innervate the cochlear nuclei in the lower pons. Second order neurons from the cochlear nuclei cross to the opposite side, ascend in the lateral lemniscus, pass through the inferior colliculus and join the medial geniculate body. Third order neurons from the medial geniculate body enter the auditory area in the superior temporal gyrus. That is in brief about the cochlear pathway. Then vestibular nerve, bipolar cells in the vestibular ganglion located in the inner auditory canal. Peripheral processes receive the information from vestibular apparatus, that is saccule, utricle, and semicircular canals. Central processes form the vestibular nerve. Okay. They run past of the cerebellar pointed angle to enter the brainstem and the pontomedullary section. Innervate the vestibular nuclear complex. Fibers from this vestibular complex connect the oculomotor nerve nuclei through medial longitudinal fasciculus and also connect the focal-nodal lobe of the cerebellum through vestibulocerebellar fibers. Connect the cell bodies in the spinal cord through vestibulospinal tract. So these are the connections of the vestibulocochlear nerve. This already dealt with. The muscles innervated, I told you already. Extraocular muscles through medial longitudinal fasciculus form vestibulo-ocular reflex to maintain the vestibulo-ocular reflex to maintain the body balance in dark. Because vestibular apparatus in the pons, they have the central processes ascend upwards into the medial longitudinal fasciculus to connect the ocular nerves, oculomotor nerves. Okay, they maintain the vestibulo-ocular reflex in order to balance the body in dark. Spinal muscles are innervated via the lateral and medial vestibulospinal tracts, innervating the cell bodies at the sacral segment of the spinal cord. This is all about the applied neuroanatomy related to the vestibulocochlear nerves. Now coming to the brief note on the clinical significance. There could be congenital anomalies, there could be trauma, infections, tumors, or vascular lesions. Acute vestibular syndrome. This is a clinical emergency. Presents with the acute onset of vertigo, nausea, vomiting, gait disturbance, and the patient cannot balance the body lasting for few seconds to hours. Nystagmus and head motion intolerance. The patient cannot move the head, lasts for days or weeks. Caused by viral vestibular neuritis. Vestibular neuritis is the common cause of acute vestibular syndrome. It is self-limiting vestibulo-ocular reflex, nystagmus, skewed deviation of absent. Central brainstem cerebellar stroke. It's a permanent, not temporary. Vestibulo-ocular reflex is normal. Nystagmus is vertical or bidirectional. Skewed deviation is present. This is the difference between the peripheral and central lesions causing the acute vestibular syndrome. Well, we have already talked about the clinical presentation of the eighth nerve injury. Presence of vertigo, nystagmus, tinnitus, and sensorineural deafness. Schwannoma is the common cause of unilateral vestibular dysfunction. Seen in the neurofibromatosis type 3, which causes bilateral acoustic neuroma. Manifests as vertigo, nystagmus, sensorineural deafness of gradual onset because it is tumor. Facial nerve involvement is uncommon. This is contrary to the acoustic neuroma. Auditory nerve injuries could be due to trauma, demyelination, we see in the multiple sclerosis, congenital anomalies in the form of hypoplasia, vascular lesions causing infarcts. Well, this is in brief about the neuroanatomy of the vestibulocochlear nerve and its clinical significance. Thank you very much for the patient listening, and we'll meet you again in the next class. Until that time, bye bye.